Hello, my name's Sarah Willems. This is my capstone project. It was midline catheters versus PIVs and choosing the best option in the neonate. My practicum setting was at Kentucky Children's Hospital in the neonatal intensive care unit, where I worked alongside the neonatal vascular access team, commonly referred to as the PIC team. The role of the PIC nurse includes providing ultrasound guided IV placements, placing PIC lines along as well as midlines, also known as long PIVs within the unit, performing central line dressing changes, changing dressings for midlines, and assisting in difficult IV placements and lab draws. The PIC team covers the neonatal intensive care unit at KCH as well as neonates within the PCICU, so the pediatric cardiac intensive care unit, and the PICU, so Pediatric Intensive Care Unit. Their hours can vary, sometimes running 24/7, but typically they work Monday through Friday from 7 a.m. to 7 p.m. and sometimes Fridays, usually Saturdays and Sundays from 7 p.m. to 7 a.m. with an occasional day shift on the weekends. There are currently 3 full-time PIC nurses as well as 3 part-time PIC nurses on the neonatal vascular access team. Additionally, we have a nurse practitioner who is also certified to place these PIC lines and occasionally cover shifts when all nurses are pulled to staff or when coverage is needed, particularly during those night shifts. My preceptor was Veronica Stewart, who's been a successful nurse for 23 years here at UK, with the past 7 years spent as the PIC nurse in the NICU. She was a wonderful preceptor and is very knowledgeable about all aspects of the PIC team. Here's an overview of the KCH's neonatal intensive care unit. The NICU has 3 areas under its management. The first floor, an area on the 3rd floor called 3 Neo, and another area outside of the PICU that's called 4 Neo. The first floor is designated for those sickest of infants and has beds for approximately 73 babies. The 3 Neo area also serves as a step-down unit and provides care for infants who are improving with a capacity of 16 beds. Lastly, 4 Neo is specifically designated for those infants who are withdrawing from substances. The primary learning goal for my practicum experience was to understand the difference between peripheral IVs as well as midline catheters. I aim to educate nursing staff about these different types of access lines, including their risks and benefits, as well as the rationale for selecting and advocating for one access type over the other. My learning objectives for the Capstone project were to identify any current uses and treatments for both PIVs and midlines for the neonates within the unit. I also aimed to determine how frequently patients using PIVs for their therapy required multiple attempts and how often these catheters were lasting less than 2 days, despite the need for any IV therapy that was lasting longer than any 4 days. Additionally, I sought to explore the benefits of using midlines over PIVs, and I planned to educate bedside nursing staff on the difference between these access types and shared the information we gathered above. So a quick comparison of midlines and PIVs. A PIV is a short venous catheter with a typical insertion site for neonates, including the hand, forearm, foot, and scalp. PIVs are recommended for administering non-vesicant fluids such as dextrose that's up to 12.5%, TPM with an osmolarity of 900, and many medications that are gentle within the vein. These catheters are suitable for fluids intended for use of fewer than 4 days and blood products. PIVs can be saline locked and do not require any heparin for maintaining patency. In contrast, a midline catheter is an extended dwell version of a PIV. Midlines are longer and more durable than PIVs, measuring between 8 centimeters and 15 centimeters depending on the size of the infant. Midlines are placed under sterile conditions with common insertion sites including the upper forearm, lower extremity, and the scalp. When properly positioned, the distal tip of the forearm should be located at or below the axillary vein, and in the lower extremity it should be positioned below the inguinal fold. Midlines are suggested for administering non-vesicant fluids and therapies intended for up to 4 weeks. It is advised to use a small dose of heparin in accordance to whatever the unit policy may be, either in the infused fluids or through a heparin lock to ensure the catheter patency and prevent any occlusions. Midlines. Benefits to midlines over any PIVs. So midlines offer several advantages over the use of a PIV line. Compared to PIVs, midlines require fewer catheter insertion attempts. They exhibit improved dwell times compared to that of the PIV. They've been shown to result in fewer complications related to any insertion or maintenance. Additionally, to pose a lower risk of extravasation, which ultimately enhances the quality of that patient care. For the last learning objective, the education that I provided to the staff was delivered in person as well as accompanied by a handout. So I visited each hallway to explain the differences between the two types of catheters to bedside nursing staff. I then distributed a handout that highlighted any key points regarding the difference in access types and discussed the scenarios in which it may be appropriate to advocate for the PICC team to place a midline catheter instead of attempting multiple PIV insertions for a patient requiring access for longer than any 3 days. At the end of the practicum, I returned to each hallway to follow up with the bedside nursing staff. I asked them how helpful they found that the education may have been and the handout, and whether they felt more confident advocating for the appropriate use of access types for their patients. I discovered that the nurses felt more confident after the education and felt better prepared to advocate for midline catheters when faced with situations that warranted them instead of use of multiple PIV attempts. A comparison of the literature to the practicum site. In my experience, midlines are not as commonly used as a PIV line in the KCH NICU. We did observe that many patients required multiple attempts to establish PIV access on their first stick, and several infants needed additional PIVs to complete the therapies lasting longer than 3 to 4 days. This resulted in a high rate of PIV attempts and failures, often involving several nurses to attempt to secure a PIV for a single infant. Research and literature, so that indicated that successfully placing PIVs on the first attempt in infants can actually be quite challenging. Sykes and colleagues reported a first attempt success rate of only 45% in neonates, with an infant averaging 2.22 attempts per access. Their study also showed that fewer patients in the midline group compared to the PIV group required additional access devices. Furthermore, midline use was associated with greater patient satisfaction and lower healthcare costs. Another study found that midlines were actually more cost-effective than PIVs, and the third and final study suggested that midlines were actually more beneficial than PIVs in neonates with a birth weight greater than or equal to 1,500 grams, which is kind of significant because a lot of these infants are actually greater than 1,500 grams. So best practices. Literature indicates that using midlines can reduce complications, minimizing the number of venous access attempts needed when IV therapy is required for more than a few days, and offer a cost-effective solution. It's important to consider that neonates require special attention, as multiple attempts to place a PIV line can cause distress not only for the infant, but also for family members, leading to a loss of trust in the medical staff. Research suggests that midlines should be utilized when IV therapy is anticipated to last longer than 3 to 4 days, given that PIVs typically need to be replaced about every 48 hours. In the practicum site, midlines are usually placed only after PIV attempts. PIV placement has exceeded the current protocol of 5 to 6 attempts in a single day, or if the infant required therapy for longer than 7 days. So I believe this is some kind of practice that could be utilized better in the unit. Literature also emphasizes that midlines must be inserted using sterile techniques and a small amount of heparin. At the practicum site, the PICC team successfully places these lines under these conditions using a required volume of 0.5 units per ml of heparin, administer at a minimum rate of 1 ml an hour to ensure the line patency. While many studies suggested that midlines could be used for blood product administration, the practicum site currently prohibits this practice. Instead, it requires either the placement of an umbilical catheter or a PIV for blood transfusions. So my reflections on this practicum experience. I thoroughly enjoyed my experience during the practicum. I genuinely take pleasure in placing peripheral lines, and I find the responsibility of PICC nurse quite intriguing. This seems like a career path I would actually like to pursue in the future. I believe the research I conducted during this practicum will make a meaningful difference within the unit. All the education I provided to these nurses potentially can help infants avoid any multiple attempts at placing PIVs. References: here are my 3 articles that I use for my literature research. Thank you so much.